I have a few questions for our speakers as well as our HAI IPs. Karen, I'll start with you. How has the UTI impacted admission rates? And have you seen any increase in the numbers?
Thank you, Shantala. Yes, we actually have seen an increase in the number of UTIs, but not only in UTIs, upon doing the deep dive into the data, we have seen an unbelievable rise in urosepsis cases. So with that being said, we know that a resident doesn't wake up with sepsis condition, right? It comes from somewhere. And when we did the review, we found that, the hospitals want that high specificity, so they're going to go for that unique diagnosis. The majority being urosepsis and pneumosepsis, and then followed by the skin, that starts with a cellulitis or a wound ulcer. So again, if there is not a process in place to be able to identify signs of a UTI, as I quoted Drucker, if we don't know what's broke, we are not going to know how to fix it, then there's going to be that higher risk for UTI with a chance to evolve into the bacteremia. So with that said, we need to be mindful that there are those cases that are diagnosed as bacteria, right? And it's falsely diagnosed as a UTI and are still getting treated. So that prompts us to have that further and ongoing education, right? To keep just drilling it into everybody's heads.
Thank you, Karen. Next question goes to you again. How CMS is looking into UTI metrics to identify facilities of concern?
Great. So at this time, CMS shared with HSAG facilities with high infection rates that's based on data. So in other words, a resident gets transferred to the hospital from the facility and is admitted. At discharge, the diagnosis coded was a UTI. So again, very important to identify those high-risk residents to prevent the infection and catch any sign or symptom early to prevent that hospitalization in the first place. I also recommend for the buildings to look at the diagnosis upon return to the facility so that you'll have a clear number of UTIs. So we, I want to mention that we are aware of facilities getting residents from the hospital with no evidence of the UTI, but coded with that diagnosis and on antibiotics. So with that said, while there's no 100% solution to prevent this, right? Communication with the hospital, such as a case manager or social worker prior to the transfer may be helpful. And then if needed, reaching out to the physician who's following the resident at your facility or to the medical director for further assistance and ongoing communication.
Thank you, Karen. The next question to Zenith, Hillary, and Karen, any one of you can answer, or all three of you can answer. The many facilities, the many skilled nursing facilities, their biggest challenge is regarding MDs who usually order for routine UA, routine culture, and as well as they order for routine change of Foley catheter or the bag. If you can explain how the IPs and DSTs can tackle this situation.
Sure, I can start, and then Zenith, Hillary, you can just chime in. So first and foremost, communication with the physician and the family, and making every attempt to remove that indwelling catheter, utilizing the CAUTI audit tool that Jack showed you can help you identify those residents who may be candidates for voiding trials, and then involving the MDs and family members in care plan meetings so that they have that voice. Ensure your policies and procedures are up to date and are supported by the evidence-based practice, as we talked about with the action plan. And then utilize your medical director or identify that physician champion that may be able to help with those conversations, and have them with the ordering physician also explaining to the family how changing that catheter system frequently can increase the resident's risk of infection. So those are just a few things that I can think of. Zenith, Hillary, I don't know if there's anything you'd like to add to that.
I think you've covered it all.
Yep, I think you've covered it all as well. Thank you.
Oh, thank you. Okay.
Thank you, Karen. Thank you, Zenith, Hillary. Next question goes to our IPs with their experience in the acute care setting. So why is it important to have the policy defining ABUTI, SURI, and CAUTI? Can you explain?
I suppose I can start real quick. So yeah, there's definitely several benefits to having written policies and procedures and protocols for UTI prevention. Essentially, having those policies helps to ensure that our practices are based, on current guidelines from the CDC, and they are also the framework that you will use to build your training and competency assessments for your staff.
Yeah, those are really important. The only other thing I could add is, having the policies and procedures that Hillary just mentioned, you can then educate the residents and the family members that, this is the practice that we engage in here, and this is the policy procedure that it's based on, which is also then based on, CDC guidance. And then if you have questions from physicians or anyone else, you can always refer to the policy and procedure. So I think it empowers your staff to be able to talk to residents, family members, and physicians when you have a very robust policy and procedure.
Thank you so much, Zenith. Hillary. Karen, this question goes to you. Can you talk about indications for Foley catheter? Can you give some examples for alternative for Foley catheter for incontinent patients? We saw some of the response was they were one of the indication they thought was incontinent residents. Can you give example for alternatives?
Sure. So for the incontinent resident, as previously mentioned on the risk assessment action tool, using the incontinent pads are an alternative, making sure to do appropriate and frequent peri-care, purposeful rounding every 2 hours with toileting opportunities, checking the incontinent pads frequently to prevent that skin exposure to soiled pads. We don't want to use that indwelling catheter, but external catheters are an alternative, and we want to make sure that we do that proper perineal care with using those external catheters as well. Thank you.
Can you give some alternative example for acute urinary retention or obstruction? The first thought process is we need to insert Foley catheter. What is the best practice before we insert the Foley catheter?
So initially, if possible, we want to use that bladder scan to determine the amount of urine retained. And if it is a significant amount, as much as we don't want to encourage any catheter use, evidence shows us the straight catheter is much less risky than using an indwelling catheter. And I think I saw that question come up in the chat. So the indwelling catheter would be our least choice. And even though it doesn't seem the way that using the straight catheter is much less riskier, even though it doesn't seem so because you're inserting in several times rather than just the one time for the indwelling. But evidence shows us that that's the choice, not the indwelling.
Thank you, Karen. This goes to Hillary, Zenith, Karen, any one of you can answer. Can you give some examples how to involve residents and their family members as part of this UTI prevention bundle?
So I can start, and Hillary and Zenith, please chime in. So again, as I mentioned earlier, having the family involved in the care plan meetings, and then using that visual cue poster that I shared with everyone to explain the purpose of it and how they can help. It's simple, easy to read, easy to see. And I want to mention we're coming out with that in Spanish as well. So I'm excited about that. We will send the notice out to everybody or keep checking the link for that. Those are mainly what I see as key items to involve the resident and family members. Hillary, Zenith, anything else you'd like to add?
No, I don't think there's anything more that I would add. I think that covers it very well. Thank you, Karen.
Okay.
Zenith, anything?
Yeah, I'm just thinking that I think that's a great thing to do, right? To involve family members in the care of the residents. And yeah, all of those are great. I think maybe adding something to the admission packet. So from the very beginning, the family members and the resident, they're aware of the expectations and what things are going to be or not going to be done in terms of UTI care. Making sure residents have, as was mentioned previously, have all the supplies that they need for peri-care, right? If they're doing their own peri-care, or if the staff is doing the peri-care, just to continue to offer it, right? Maybe they might decline peri-care when first offered because they're not feeling well, or they would rather have breakfast first and then have their peri-care. So instead of just saying patient or resident refuses and charting it as that, maybe having a different staff member, maybe they have their favorite LVN working that day, or offering it again at a better time, maybe after they've been medicated or after they've had breakfast, instead of just charting that they refused and waiting. Yeah, definitely getting the family members involved so that when the family does come and visit, then maybe they can address that as well. That make sure that you're drinking your water, make sure you're doing your hand hygiene, make sure you're getting up and ambulating, make sure you're saying yes to pericare. So I think all of those things are important.
Thank you, Zinat. Hillary, Zinat, this question goes to both of you. Can you go over the importance of pericare, and then can you give some examples how our IPs and DSDs can improve the compliance, especially for how to provide training for our staff? Thank you.
Sure. Well, I mean, as it's been mentioned many times throughout our training session today, and the pericare is probably one of the most important prevention practices that needs to be implemented to prevent UTIs. So having easy access to the supplies, ensuring that you have all the supplies available closely, educating your staff on and providing competency on how to do the appropriate pericare procedure is also very important. And then, as Zenith mentioned, including that education material in an admission packet would be helpful. And then also in making sure you're following your policy with regard to the pericare and the frequency of the pericare. So that should be done at least once a day to prevent skin breakdown and reduce the burden of organisms that are in that area, which causes all those infections.
Thank you, Hillary. Zenith, anything to add?
Hillary covered it all. Thank you.
Thank you, Zenith. Thank you, Hillary. I would just like to add, so engaging any residents who are alert and oriented, so making sure that they know how to do the pericare by themselves. So making sure all the supplies are easily accessible to the staff. We have seen the gaps in our acute care setting that can happen in skilled nursing facilities too, when there is no easy access to the supplies, then there is always shortcut the staff will take, and compliance will be lacking. So with that, we will go to our few of our chat questions. Karen, this goes to you, you and Jeff. There are a couple of questions regarding surveillance criteria. Can they use Meggers criteria, Loeb's criteria, or do we recommend NHSN surveillance criteria? Which one do we prefer?
So Jeff, do you want to speak to this? I can speak to the McGreer's criteria. And if you'll notice, our tools are very similar to McGreer's criteria, just a one-page simple format. So I know a lot of buildings use McGreer's.
Yeah, and I would say not necessarily recommending one over the other. They are very similar. What I like, and I know I come kind of from the hospital side, so like the NHSN, but what I like is they update it, annually. So, each year it's sort of updated surveillance guidance. And I know McGeer's hadn't been updated for years and years and years. And I think it was about 10 years ago they did an update, which was, I think, kind of aligned, or NHSN aligned it with it at that time. I think NHSN has just made a few tweaks since. So very similar. And as far as Loeb's, I feel like, where McGeer's and NHSN are like a surveillance definition criteria, Loeb's is more of a clinical decision making. So kind of looking at two different sides there.
And use more for antibiotics direction too, Jeff?
Yeah, exactly. So for the sort of that treatment, clinical treatment and decision making.
Thank you.
Thank you, Jeff. Thank you, Karen. The next question, Hillary, Zenith, I'll pass it on to Hillary. Regarding Maria had asked a question. So I have, after treating UTI with antibiotic therapy, should a follow-up urine analysis should be done? What's your recommendation, Hillary?
No, actually, no, your analysis is not recommended after antibiotic therapy. And that is just one of those CDC recommendations. Also, even after antibiotic therapy, a resident can still be colonized with those organisms. So it's not recommended.
Thank you, Hillary. There is no test of cure. Just like if you all remember, for even C. diff, we don't do the test of cure. Zena, this question to you, and if we need more detail, we can bring it back to our office hour. Do you have anything to recommend when using PureWick? Michelle, I'm not clear on the question. If you want to come off of mute and ask, go ahead.
Just like for like do we do this like an actual perennial care?
Yes, Zena, do you want to take on that to the pericare, even if they're using PureWick?
Oh, okay, yes,
Or
yeah.
Changes, frequency of changes?
Okay,
Yes,
I think
you still want to do pure, I'm sorry, go ahead, Shantanu.
no, go ahead, Zena, sorry.
No, I was just going to address pericare should be done regularly, regardless of use of PureWick or not. So in fact, you can provide really thorough pericare since the PureWick just sits on the outside, so you can remove that and do the pericare and replace the PureWick. Was there something else?
I think the additional question Michelle was asking about the changing the pad, how frequently I think they had to change that it all depends upon, so how often do they need to change? Hillary, do you have any recommendation, or it's all?
Sure. Well, are we talking about the PureWick? The PureWick, yeah, based on the manufacturer's recommendations, or as necessary if it becomes saturated. Well, and I know from my own experience working in acute care hospitals, the PureWick, I think it's every 12 hours, unless you need to remove it sooner.
Thank you, Hillary. Mm-hmm. So there's a question regarding the acute care do routine urine analysis when the residents are sent to ED. So hospital does the recommendation. They start with an antibiotic and then they send them over to the skill side. So any guidance, Karen, how to manage this kind of a situation?
Well, again, ongoing communication and education, reaching out, possibly having the medical director talk with those physicians at the ED, at the acute care facility. We've seen and heard about stories where residents going out for chest pain, coming back with UTIs when there were no signs and symptoms. So unfortunately, there's no 100% resolution to this. We just have to keep those lines of communication open, asking questions, and really, I think that's the most that we can do. We can't control everything, so we can only control what we control, right? And using the medical director as a vice to start those communications. Zenith, Hillary, anything else you can suggest or you've seen that works?
Yeah, that's a challenge. I mean, that's definitely a challenge. And I believe, I know in emergency departments and hospitals, it's frequent practice to do a urinalysis on essentially everyone that comes into the ED. It's not just those residents coming from skilled nursing facilities, but it should be reserved for only those that have signs or symptoms.
I guess that's another reason why we want to prevent that UTI, so we don't even send them to the hospital in the first place to have that UA ran or done, right? Mm-hmm. So if we prevent them from going into those doors, then we won't have to, it won't be such an issue. So use the toolkits, everybody.
Thank you, Hillary. Thank you, Karen. I think that's an unresolved question right now. So all of us have to work together to address that situation. And there are a couple of questions which we will address during our office hour, especially one for the UTI prophylactic treatment. We usually, we don't recommend any prophylaxis treatment treatment for UTI, but we will address that during in more detail during our office hour. With that, I think there's a couple of questions regarding whether the resident need to be in a contact precaution versus enhanced standard precaution. We will respond to that too.